Pause the video and carefully scrutinize nausea and vomiting before advancing to the next slide. As a way of introduction, nausea and vomiting are common complaints in humans. The severity of the event can range from a slight discomfort or queasiness to uncontrollable, forceful vomiting. Despite this range, all are perceived to be uncomfortable and troublesome and should be treated in a proper and timely manner. Patients may refer to this experience by many different names: upchuck, URP, queasy, throw up, puke, to name a few. There are many different causes of nausea and vomiting, such as motion sickness, pregnancy, and medications. Likewise, many treatment options can be used to manage this complication. People of all ages experience emesis, although the etiology may be related to age-specific factors. Drugs are most frequently used for the treatment of nausea and vomiting, but alterations of non-drug factors may decrease the severity of emesis. This chapter reviews the pathophysiology and pharmacotherapy of specific types of nausea and vomiting. Next, we will discuss the causes of nausea and vomiting. There are multiple causes for nausea and vomiting. However, some of the most common are from the ingestion or administration of substances or drugs, gastrointestinal disorders, neurologic processes, and metabolic disorders. The presence of noxious stimuli is frequently a cause of nausea and vomiting. Supratherapeutic digoxin, marketed as lanoxin, and theophylline, marketed as Theodur or Slowfilin, are known to produce emesis. Nausea and vomiting occur more frequently with high-dose chemotherapy than with moderate doses of the same drugs. Erythromycin and some penicillin derivatives are acknowledged for inducing uncomfortable gastrointestinal complications. Emesis can also result from excessive ethanol intake. It is well known that other sensory experiences, such as pungent odors or gruesome sights, can induce nausea and vomiting. Box 28.1 presents specific etiologies for nausea and vomiting. Patient-specific factors that increase susceptibility to nausea and vomiting include age, previous nausea and vomiting experiences, and sex. Most of the research identifying these characteristics was done in patients receiving chemotherapy. Poor control of nausea and vomiting with previous surgeries or chemotherapy predisposes a patient to subsequent episodes of emesis, also referred to as anticipatory nausea and vomiting. This form of emesis is often difficult to treat with standard antiemetics. One study of patients with cancer reports a threefold increase in the incidence of emesis in patients previously treated with chemotherapy compared with chemotherapy-naive patients treated with identical chemotherapy regimens, according to Pistas and Chris in 1992. Adult patients younger than age 30 have an increased incidence of emesis compared with their older counterparts. In addition, the younger patient population is more likely to experience extrapyramidal reactions from the drugs used to treat their nausea and vomiting. In patients who received the same chemotherapy and antiemetic premedications, women experienced more nausea and vomiting than men, according to Pistas and Chris in 1992. Chronic ethanol intake exceeding 100 grams per day, equivalent to roughly 5 beers or mixed drinks per day, is associated with better emesis control and decreased incidence. A history of motion sickness may increase the risks of nausea and vomiting in another situation, such as with chemotherapy or surgery. Children in general experience nausea and vomiting more frequently than adults. Obesity and anxiety have also been associated with heightened emesis incidence. The prevalence of nausea and vomiting may complicate 11% to 73% of surgical procedures. Prevalence is also increased by the use of certain inhalation agents, nitrous oxide, in particular, and by concomitant use of opiate medications. The use of propofol as an intravenous anesthetic agent lowers the risk of postoperative nausea and vomiting, PONV. Postoperative nausea and vomiting is more likely to occur after general than regional anesthesia, and its prevalence increases in parallel with the duration of surgery and anesthesia. Postoperative nausea and vomiting is especially common after gynecologic and middle ear surgery and also occurs more commonly with abdominal and orthopedic surgery than with laparoscopic or other extra-abdominal operations. Postoperative nausea and vomiting is also more likely in those with a history of postoperative nausea and vomiting or motion sickness. Pause the video and carefully scrutinize box 28.1 summarizing the etiologies of nausea and vomiting before advancing to the next slide. Pause the video and carefully scrutinize Figure 28.1 illustrating the pathophysiology of nausea and vomiting before advancing to the next slide. Next we will discuss the pathophysiology of nausea and vomiting. The pathophysiology of nausea and vomiting is complex, as shown in Figure 28.1, and involves the modulation of medullary sites and neurotransmitters. Many sensory centers accept noxious stimuli from the body, including the chemoreceptor trigger zone, abbreviated as CTZ, visceral afferent nerves, cerebral cortex, limbic system, vestibular system, and midbrain intracranial pressure receptors. Let's now shift gears to modulation of nausea and vomiting. These stimuli are transmitted to the vomiting center, also called the emetic center, which coordinates the sensory inputs and the act of vomiting. The vomiting center is the key component in the modulation of nausea and vomiting. Located in the lateral reticular formation of the medulla, it receives afferent impulses from the aforementioned sensory centers. On activation of the vomiting center, efferent impulses are sent to the nucleus tractus solitarius, an intertwined neural network that innervates the salivary, vasomotor, and respiratory centers and cranial nerves 8 and 9. Efferent impulses are also sent to the stomach, abdominal muscles, diaphragm, and associated sphincters to execute the involuntary act of vomiting. Much like the sensory centers that stimulate it, the vomiting center is rich in dopamine, histamine, serotonin, and acetylcholine receptors and can also be affected by binding to opiate and benzodiazepine receptors. An intact vomiting center is essential for coordination of the vomiting act. Next we will discuss stimulatory centers. The chemoreceptor trigger zone is one of the most important chemosensory organs responsible for the detection of noxious stimuli. It is uniquely located in the area postrema in the floor of the fourth ventricle of the medulla, brain and is exposed to both blood and cerebrospinal fluid, CSF. Thus, toxins in both the blood and cerebrospinal fluid can stimulate a response by the chemoreceptor trigger zone. These toxins may be drugs, e.g. chemotherapy, opiates, and digoxin, poisons, or substances found naturally in the body, excess calcium, or hormones. The chemoreceptor trigger zone is rich in neurotransmitter receptors for dopamine, serotonin, histamine, and acetylcholine. An antiemetic effect is elicited when these receptors are blocked. Let's now look at the gastrointestinal tract. The GI tract and pharynx are sites of origin for the stimulation of nausea and vomiting. Visceral afferent nerves, also referred to as splanchnic nerves, from the pharynx and gastrointestinal tract transmit impulses from local neuroreceptors along the vagus nerve to the vomiting center. The gastrointestinal tract is rich in local dopamine, histamine, and serotonin receptors. The visceral afferent nerves are also responsible for transmitting stimuli from other peripheral sites such as the heart, lungs, and testes. Hence, the vomiting response may occur when a person has been punched in the abdomen or kicked in the groin. Abdominal surgery is another example in which visceral afferent nerves are involved in nausea and vomiting. We will now look at the central nervous system. Motion sickness is primarily a central nervous system (CNS) response mediated by the vestibular system. Acetylcholine and histamine receptors have been found in the vestibular center. Blockade of these receptors provides some degree of protection from emesis. The cerebral cortex, the largest portion of the brain, is responsible for the motor coordination of the body, sensory perception, learning, memory, and many other functions. Afferent impulses from specific sites of the cerebral cortex can result in emesis. The cerebellum is responsible for the regulation of balance, equilibrium, and coordination. Disruption of this portion of the brain can lead to temporary or chronic nausea and vomiting. These structures may also play a role in anticipatory emesis. Next we will discuss the limbic system. The limbic system and the midbrain intracranial pressure receptors can stimulate nausea and vomiting, although their mechanisms are not fully understood. In humans, the primary function of the limbic system is associated with the expression of mood, emotions, and feelings, as well as memory recall. Anxiety, fear, and other emotions may play a role at this site in the perception of nausea and vomiting. Head trauma, intracranial bleeding, and mass effect from a benign or malignant tumor can produce increased pressure in the brain. This increased intracranial pressure can cause nausea and vomiting. The optimal treatment in these situations is a reduction in intracranial pressure through surgery or corticosteroids. Next we will look at the diagnostic criteria. The three identified phases of emesis are nausea, retching, and vomiting. Nausea is the unpleasant physical sensation of impending retching or vomiting. Nausea often occurs without the other two steps of emesis, although they are all treated with the same pharmacologic agents. Common symptoms accompanying nausea are flushing, pallor, tachycardia, and hypersalivation. Gastric stasis, decreased pyloric tone, mucosal blood flow, and contractions of the duodenum with reflux into the stomach are physiologic responses to nausea. Retching, the second phase of emesis, is the involuntary synchronized labored movement of abdominal and thoracic muscles before vomiting. Vomiting is the coordinated contractions of the abdominal and thoracic muscles to expel the gastric contents. The lower esophageal sphincter contracts, allowing gastrointestinal retroperistalsis. The actual expulsion of gastric contents differentiates vomiting from retching. The acuteness of the symptomatology is based on history and physical examination. Several issues need to be addressed, such as whether this is an acute emergency, such as mechanical obstruction, perforation, or peritonitis, clinical clues that the problem is likely to be self-limited, such as would be expected with viral gastroenteritis or a potentially offending medication. The goal is to determine whether empiric treatment with an antiemetic, a gastric acid suppressing, or a prokinetic agent would be beneficial, or whether the patient should be admitted to the hospital to correct fluid and electrolyte imbalance. Acute nausea and vomiting differs considerably from that of chronic nausea and vomiting, so symptom duration is important. Acute onset of nausea and vomiting suggests gastroenteritis, pancreatitis, cholecystitis, or a drug-related side effect. When nausea and vomiting are associated with diarrhea, headache, and myalgias, the cause is viral gastroenteritis. In this instance, symptoms should resolve spontaneously within 5 days. A more insidious onset of nausea without vomiting is suspicious of gastroparesis, a medication-related side effect, metabolic disorders, pregnancy, or even gastroesophageal reflux disease. Nausea and vomiting are considered chronic when their duration is longer than 1 month. Timing and description of the vomiting are important. Vomiting that occurs in the morning before breakfast is typical of that related to pregnancy, uremia, alcohol ingestion, and increased intracranial pressure. Projectile vomiting suggests intracranial disorders, especially those that result in increased intracranial pressure. In this case, vomiting may not be preceded by nausea. The onset of vomiting caused by gastroparesis or gastric outlet obstruction tends to be delayed, usually by more than 1 hour, after meal ingestion. Vomiting may be suggestive of psychiatric disorders. Associated symptoms, such as abdominal pain, fever, diarrhea, vertigo, or a history of a similar contemporaneous illness among family, friends, or associates are important data to gather. The physical examination looks at vital signs for signs of dehydration, jaundice, lymphadenopathy, abdominal masses, and occult blood in the stool may reveal features suggestive of thyrotoxicosis or Addison disease. The abdominal examination should look for distension, visible peristalsis, and abdominal or inguinal hernias. Areas of tenderness are important. Tenderness in the mid-epigastrium suggests an ulcer. In the right upper quadrant, cholecystitis or biliary tract disease. Auscultation may demonstrate increased bowel sounds in obstruction or absent bowel sounds in ileus. We will now discuss initiating therapy. The treatment of nausea, retching, or vomiting in any patient begins with an evaluation and correction of possible causes. Most sources of nausea and vomiting may be reversed or palliated by surgery or medical interventions. Infectious causes should be promptly treated with antibiotics, and metabolic disorders require medical management. Some drug toxicities may be treated with antidotes, such as digoxin toxicity reversed with digoxin immune Fab, marketed as Digibind. The following section discusses medications used to treat nausea and vomiting. They should be used with definitive treatments when possible. Alterations in a patient's daily activities may aid in managing nausea and vomiting and decrease the resources used to control the problem. Non-pharmacologic management of nausea and vomiting should be tailored to the presumed etiology. Changes in a patient's diet may affect the frequency or severity of nausea and vomiting, such as avoidance of spicy foods and excessive grease or oil, and decreased caffeine intake. Professional counseling or group therapy may prove favorable for patients with psychogenic nausea and vomiting. Hypnosis, behavior modification, and imagery are beneficial tools in controlling nausea and vomiting that has an anxiety component, such as chemotherapy-related anticipatory emesis. However, prevention of anticipatory nausea and vomiting is the optimal form of management. Next we will discuss goals of drug therapy. The goals of drug therapy are simple: to alleviate the subjective feeling of nausea and the objective act of vomiting and their associated complications, as shown in box 28.2. It is important to rely on the patient's subjective response when evaluating the efficacy of a specific therapy for nausea. Secondary goals are to minimize drug toxicity or adverse events and contain costs. The prevention of nausea and vomiting is the goal in the setting of chemotherapy and certain surgical procedures. Control or improvement in nausea and vomiting should occur within 5 to 60 minutes of a pharmacologic intervention. If this does not ensue, another method should be used promptly. Table 28.1 reviews available antiemetic agents, dosages, comparable efficacy, and adverse effects. Pregnancy risk factors are included in the discussion of each drug class and in the pregnancy-related nausea and vomiting section. Next we will discuss phenothiazines. Phenothiazines are a commonly used class of drugs to treat nausea and vomiting. Prochlorperazine, marketed as Compazine, and promethazine, marketed as Phenergan, are the most frequently used drugs in this class. Next we will discuss the mechanism of action of phenothiazines. Their mechanism of action presumably involves dopamine receptor blockade in the chemoreceptor trigger zone. Anticholinergic activity in the vomiting and vestibular centers of the brain may also contribute to the mechanism of action. The phenothiazines may be used as monotherapy for mild to moderate nausea and vomiting, or in combination with other antiemetics for more severe nausea and vomiting. A dose-response quality has been noted for this drug class. However, the incidence of adverse effects such as extrapyramidal effects and sedation can also be associated with higher doses. Promethazine has activities of an antihistamine antiemetic and could also be classified with the antihistamine anticholinergic class of drugs. The phenothiazines are a viable and practical option for long-term treatment of nausea and vomiting. Products are available in oral, rectal, and injectable formulations. To improve tailoring of the drug regimen to the patient, oral preparations are available as tablets, sustained-release capsules, and liquids. Rectal suppositories are useful in patients who cannot retain oral medications and when intravenous access is not an option. Suppositories should be avoided in patients who are thrombocytopenic because of the increased risk of bleeding or hemorrhage. Pause the video and carefully scrutinize box 28.2 summarizing complications of nausea and vomiting before advancing to the next slide. Next we will discuss contraindications. Caution should be used in patients taking concomitant drugs that cause CNS depression, such as sedatives, hypnotics, and opiates, because further sedation may result. Phenothiazines may exacerbate the symptoms of Parkinson's disease. The safety of phenothiazines during pregnancy is controversial. Most studies find phenothiazines to be safe for the mother and fetus if used occasionally in low doses. Most phenothiazines are in pregnancy risk category C. Phenothiazines may decrease the seizure threshold and should be used cautiously in patients with seizure disorders. The phenothiazines are relatively inexpensive in relation to most of the other drug classes, with the exception of the sustained-release phenothiazine preparations, which tend to be costly. Next we will discuss the adverse events of phenothiazines. The most common adverse event of phenothiazine use is drowsiness or sedation. Phenothiazines also have the ability to evoke extrapyramidal symptoms, abbreviated as EPSs, by blocking the central dopaminergic receptors involved in motor function, particularly at higher doses. Extrapyramidal symptoms may present as dystonic reactions, feelings of motor restlessness, and Parkinsonian signs and symptoms. Mask-like face, drooling, tremor, cogwheel rigidity, pill-rolling motion, lack of ability to initiate voluntary movement, and gait abnormalities are all severe examples of Parkinsonian presentations. Dystonic reactions may include spasm of the neck muscles or torticollis, extensor rigidity of back muscles, mandibular tics, difficulty swallowing or talking, and perioral spasms, often with protrusion of the tongue. Motor restlessness may consist of agitation, jitteriness, tapping of feet, and insomnia. Extrapyramidal reactions can be easily treated with the use of diphenhydramine, marketed as Benadryl, 25 mg orally or parenterally 3 to 4 times a day, or benztropine, marketed as Cogentine, 1 to 4 mg orally or parenterally twice a day. Autonomic responses, such as hypotension and tachycardia, have been observed with IV phenothiazine use, particularly chlorpromazine. Hypotension and sedation are less likely to occur with prochlorperazine, thiethylperazine, and perfenazine, but these three agents are associated with a higher frequency of extrapyramidal symptoms. Dry mouth, urinary retention, blurred vision, and other anticholinergic effects may occur with phenothiazine use. Reversible agranulocytosis is rarely associated, that is less than 1%, with phenothiazine therapy. This effect occurs more frequently in women and with chronic phenothiazine use. Cholestatic jaundice and photosensitivity are reactions that can occur rarely within the first few months of chronic phenothiazine use. These are more frequently observed in phenothiazine use for psychiatric conditions rather than emesis control. Monitoring parameters include extrapyramidal symptoms and Parkinsonian symptoms. Doses may need to be decreased in severe hepatic dysfunction. Complete blood counts should be regularly monitored in chronic phenothiazine use. See Table 28.1. We will now discuss interactions. These drugs potentiate CNS depression with alcohol and other CNS depressants. They potentiate the action of blockers and levels of the drug can be increased with propranolol. Anticonvulsant drug doses may have to be adjusted. They may antagonize oral anticoagulants. Pause the video and carefully scrutinize Table 28.1 summarizing an overview of selected antiemetic agents before advancing to the next slide. Pause the video and carefully scrutinize Table 28.1 summarizing an overview of selected antiemetic agents before advancing to the next slide. Pause the video and carefully scrutinize Table 28.1 summarizing an overview of selected antiemetic agents before advancing to the next slide. Let's now discuss antihistamines, which are also anticholinergics. A plethora of agents are available in the antihistamine, anticholinergic drug class. These agents are most useful for mild nausea, such as motion sickness. Hydroxyzine, marketed as Vistaril, or Atarax, Meclizine, marketed as Bonine, Antiver, dimenhydrinate, marketed as Dramamine, and scopolamine, marketed as Transderm Scop, are some of the more common agents of this class. Unlike most of the other classes of agents discussed in this chapter, some of the antihistamine, anticholinergic agents are available without a prescription. Let's now discuss the mechanism of action of antihistamine, anticholinergic agents. The mechanism of action appears to be interruption of visceral afferent pathways that are responsible for stimulating nausea and vomiting. These drugs are most frequently administered orally, but some can be given IV, intramuscularly, transdermally, or rectally. The antihistamines are particularly useful for the treatment and prevention of motion sickness. For this indication, it is recommended that a dose be taken at least 30 to 60 minutes before the event, e.g., boating, air flight, or car ride, and then repeated at regular intervals several times a day. The scopolamine patch is a highly useful agent for the prevention of motion sickness. A patch should be applied to clean, dry skin 1 to 2 hours before the potentially emetogenic event, and a new patch may be reapplied every 3 days. Many of the antihistamines and anticholinergics have been used for the treatment of nausea in pregnancy. We will now discuss the contraindications of antihistamine, anticholinergic agents. Precautions are recommended with asthma, glaucoma, and gastrointestinal or urinary obstruction. Antihistamine, anticholinergics are not recommended for nursing mothers. Next we will look at the adverse events of antihistamine, anticholinergic agents. Adverse effects limit the use of anticholinergic, antihistamines. Patients frequently experience sedation, drowsiness, or confusion. The anticholinergic effects are troublesome, including blurred vision, dry mouth, urinary retention, and tachycardia. These anticholinergic effects are also dose-related and occur more frequently as the dose increases, or the drug is given more often. Caution is warranted in patients with narrow-angle glaucoma, prostatic hypertrophy, and asthma because these patients are more prone to the anticholinergic effects of these drugs. Anticholinergic effects may be managed by non-drug therapies. Chewing gum or sucking on ice chips or hard candy may refresh a dry mouth. The intake of a high-fiber diet and adequate daily fluid consumption may curb constipation. Monitoring for anticholinergic effects is of paramount importance. Severe effects may warrant discontinuation of the drug. Symptoms of overdose may include dilated pupils, tachycardia, hypertension, CNS depression, flushed skin, or, more seriously, respiratory failure and circulatory collapse. Adverse effects occur more commonly in patients with renal or hepatic dysfunction. We will now progress to the interactions of antihistamine, anticholinergic agents. These drugs can potentiate CNS depression with alcohol, tranquilizers, and sedative hypnotics. Next we will discuss the benzodiazepines. Often used for other indications, benzodiazepines offer useful qualities to the antiemetic armamentarium. Not only do these agents treat and prevent emesis, they can cause anxiolysis and amnesia. These latter effects are particularly beneficial in anticipatory nausea and vomiting associated with chemotherapy. Lorazepam, marketed as Ativan, is the most frequently used benzodiazepine for nausea and vomiting. Its mechanism of action is not fully elucidated. However, it probably acts centrally to inhibit the vomiting center. Lorazepam has only moderate antiemetic properties and is usually used in combination with other agents to control chemotherapy-associated anticipatory nausea and vomiting and delayed chemotherapy-associated nausea and vomiting. We will now look at the dosage of the benzodiazepines. Both oral and parenteral forms of lorazepam are available. Patient-specific variables should be considered when identifying an appropriate dose. Usual oral or IV doses range from 0.5 to 2 mg at least 30 minutes before start of chemotherapy. As needed, P.R.N. antiemetic doses range from 0.5 to 3 mg IV or orally every 4 to 6 hours. To prevent over-sedation, patients with poor performance status, the elderly, or frail individuals require low initial doses of lorazepam. Patients with compromised pulmonary or poor cardiac function should receive IV lorazepam with caution and have close monitoring of respiratory and cardiac status. We will now discuss contraindications of the benzodiazepines. Lorazepam is not recommended for use in patients with hepatic or renal failure. Several studies have indicated that diazepam, marketed as Valium, may also cause fetal toxicity when administered to pregnant women, and thus should be avoided in this patient population. The benzodiazepines are in pregnancy risk category D. We will now look at the adverse events of benzodiazepines. For benzodiazepines, CNS depression occurs most often, with drowsiness, fatigue, memory impairment, impaired coordination, and confusion occurring frequently. Lorazepam has an amnesic effect that for some patients is a benefit, whereas others may find it unacceptable. Paradoxical CNS stimulation resulting in restlessness, anxiety, nightmares, and increased muscle spasticity may occur. The drug should be discontinued if paradoxical stimulation occurs. Other adverse effects include constipation, headache, and increased or decreased appetite. Parenteral administration may cause hypotension, bradycardia, or apnea, particularly in the elderly and critically ill. See Table 28.1. Monitoring parameters include cardiovascular and respiratory status for initial doses. Because the liver metabolizes the benzodiazepines, liver function tests should be assessed before dosing. The presence of adverse CNS effects should be evaluated with each clinic or hospital visit. Let's now discuss interactions of benzodiazepines. These drugs potentiate CNS depression when used with other drugs that depress the CNS and alcohol. Next we will discuss the serotonin antagonists. The serotonin antagonists are another class of antiemetics. Ondansetron, marketed as Zofran, granisetron, marketed as Kytril, or Sancuso, palonosetron, marketed as Alarxi, and dolasetron, marketed as Anzemet, are available in the United States. We will now look at the mechanism of action serotonin antagonists. These agents work by antagonizing the type 3 serotonin, abbreviated as 5-HT3, receptors centrally in the chemoreceptor trigger zone and also peripherally at the vagal and splanchnic afferent fibers from the enterochromaffin cells in the upper gastrointestinal tract. The serotonin antagonists were initially indicated for the treatment and prevention of chemotherapy-induced nausea and vomiting. They have changed the way nausea and vomiting are treated and have greatly improved the quality of life for patients receiving highly emetogenic chemotherapy regimens. Radiation-induced nausea and vomiting and postoperative nausea and vomiting are two other areas where the serotonin antagonists have been studied. The unequivocal efficacy and lack of significant adverse effects make these agents ideal for select indications. The serotonin antagonists are available orally as tablets and liquids and parenterally for IV use. Because these agents are used to prevent nausea and vomiting, oral administration in this situation is encouraged, even with highly emetogenic chemotherapy. There have been few data to support superior efficacy of one agent over another when used at recommended dosages. All of the serotonin antagonist preparations are costly and should be used conservatively and appropriately. Many institutions have created antiemetic guidelines to identify the approved indications of serotonin antagonists to optimize care and resources. The appropriateness of these agents in specific circumstances is discussed later. Next we will discuss contraindications for serotonin antagonist use. There are inadequate human data for use in pregnancy. However, animal studies do not reveal evidence of harm to the fetus. Two case reports cite the efficacy of ondansetron in the treatment of hyperemesis gravidarum, without adverse sequelae to the fetus. The serotonin antagonists are in pregnancy risk category B. The serotonin antagonists should be used with caution in breastfeeding mothers. Once again, human data are lacking, but ondansetron is distributed into the milk of lactating rats. And now let's talk about the adverse events of serotonin antagonists. Mild to moderate headache can occur in patients receiving oral or parenteral serotonin antagonists, followed in frequency by diarrhea. A few patients experience severe headaches requiring discontinuation of the drug. Other adverse effects that occur in less than 10% of patients are abdominal or epigastric pain, increased serum hepatic enzyme levels on liver function tests, hypertension, malaise or fatigue, constipation, pruritus, and fever. Rare cardiovascular effects have been reported, although a definite causal relationship has not been established. All three of the agents can cause electrocardiographic (ECG) alterations, prolonged PR interval and QT interval and widened QRS complex. This is best documented in the studies of dolasetron, but these ECG changes were deemed to be clinically non-significant by the authors, according to Ordway and colleagues in 1996. Conservatively, In patients with severe cardiac dysfunctions such as arrhythmia and heart block, the serotonin antagonists should be used cautiously. Important monitoring parameters for serotonin antagonists include baseline and follow-up liver function tests. Dosage reductions may be made for severe hepatic dysfunction. To avoid ECG-related complications, electrolyte assessment and correction of hyperkalemia and hypomagnesemia are indicated. See Table 28.1. Next we will discuss interactions of serotonin antagonists. Caution is used when given with drugs that prolong cardiac conduction interval, diuretics, and cumulative high-dose anthracycline. Let's now progress to metoclopramide and other antiemetics. Metoclopramide, marketed as Reglan, has been used to treat nausea and vomiting caused by several different stimuli. It is a highly useful agent in the treatment of diabetic gastric stasis, post-surgical gastric stasis, and gastroesophageal reflux, which may be associated with some degree of nausea. We will now discuss the mechanism of action. For these indications, metoclopramide enhances motility and gastric emptying by increasing the duration and extent of esophageal contractions, the resting tone of the lower esophageal sphincter, gastric contractions, and peristalsis of the duodenum and jejunum. Metoclopramide is also used in the prevention and treatment of chemotherapy-induced nausea and vomiting. Its mechanism of action is dopamine receptor inhibition in the chemoreceptor trigger zone. The central and peripheral actions of this agent make it efficacious in multiple clinical situations. Metoclopramide can be administered orally, IV, and intramuscularly. A sugar-free syrup exists for diabetic patients who cannot take the pills. Because metoclopramide is eliminated primarily by the kidneys, the dose of this drug should be decreased by 50% if the patient's creatinine clearance is less than 40 ml per minute. Subsequent doses are based on the patient's clinical response. Periodic assessment of renal function is prudent. Patients should be informed of the sedative qualities of this agent and that use of other CNS depressants could potentiate this effect. Next we will discuss the adverse events. The most clinically concerning adverse effects of metoclopramide are extrapyramidal symptoms. Much like the effects seen with high doses of phenothiazines, facial spasms, rhythmic protrusions of the tongue, involuntary movements of limbs, motor restlessness, agitation, and other dystonic reactions can occur. These effects occur most commonly in children and young adults, in men more than women, and at high doses of metoclopramide. 25% of adults ages 18 to 30 experience dystonic reactions after receiving high-dose metoclopramide for treatment of chemotherapy-induced emesis. Extrapyramidal symptoms occur within 24 to 48 hours of the initial dose and subside within 24 hours of drug discontinuation. High-dose metoclopramide is usually defined as 2 mg per kilogram per dose. Extrapyramidal symptoms can be prevented or treated with the addition of diphenhydramine 25 to 50 mg IV or orally. IV administration of diphenhydramine is preferred for serious presentations. Other reversal agents are benztropine and diazepam. Secondary to its actions in the intestinal tract, metoclopramide can cause diarrhea. Management of diarrhea includes discontinuation or dosage reduction of metoclopramide, increased fluid resuscitation, and electrolyte replacement. The use of metoclopramide may not be a prudent choice in a patient who already has diarrhea. Drowsiness and fatigue are noted in approximately 10% of patients. There are inadequate data for the use of metoclopramide in pregnancy. However, supratherapeutic doses in rats did not produce evidence of fetal harm. Metoclopramide is in pregnancy risk category B. Metoclopramide is known to be distributed into breast milk, but does not appear to present a risk to the infant if the mother is taking 45 mg per day or less. Next we will discuss the interactions. A hypertensive crisis can occur when metoclopramide is used with monoamine oxidase inhibitors. Additive sedation can be seen when used with alcohol or other CNS depressants. These drugs are antagonized by anticholinergics and narcotics. They may diminish gastric and accelerate intestinal absorption of drugs and food. Let's now progress to corticosteroids. Corticosteroids are usually reserved for chemotherapy-induced nausea and vomiting. Appreciation of the antiemetic properties of this class of agents occurred when clinicians observed decreased episodes of nausea and vomiting with Hodgkin disease protocols that included prednisone compared with protocols that did not include prednisone. Next we will discuss the mechanism of action of corticosteroids. The true mechanism of action in the relief of nausea and vomiting is unknown. But one postulated theory is the inhibition of prostaglandins. In nausea and vomiting secondary to increased intracranial pressure, corticosteroids provide relief by decreasing inflammation. Dexamethasone, marketed as Decadron, and methylprednisolone, marketed as Solumedrol, are the two most common corticosteroids used. However, the addition of prednisone, marketed as Deltasone, to lymphoma and leukemia chemotherapy regimens can provide heightened control of emesis. These corticosteroids are almost always used in combination with other agents in the control or prevention of emesis from highly emetogenic regimens. Corticosteroids are available orally and parenterally. The oral form is beneficial for low doses or prolonged administration, but may cause significant gastrointestinal toxicity. Patients should be encouraged to take oral corticosteroids with food to minimize gastrointestinal irritation and complications. IV administration is ordinarily used in the prevention of nausea and vomiting, primarily to avoid gastrointestinal complications. IV preparations should be infused over 5 to 15 minutes to prevent burning, flushing, and itching sensations associated with the phosphate-salt dissociation. Of the corticosteroids studied, the utility of dexamethasone has been best defined. In clinical trials, single-agent dexamethasone was superior to prochlorperazine and comparable with high-dose metoclopramide when used for mildly to moderately emetogenic chemotherapy regimens. The combination of dexamethasone and high-dose metoclopramide was the standard of care for prevention of cisplatin-induced emesis until the introduction of the serotonin antagonists. IV doses of dexamethasone as a premedication range from 8 to 20 mg. Corticosteroids should be used with caution in uncontrolled diabetic patients. Sliding scale insulin or careful alterations of oral hypoglycemic agent regimens may be used for unacceptably high blood glucose levels. Next we will discuss adverse events of corticosteroids. Although very useful, the corticosteroids are associated with many toxicities and adverse effects. Mental disturbances range from mood swings, depression, anxiety, and aggression to frank psychosis and personality changes. Men are particularly susceptible to this aggressive behavior. Headache, restlessness, and insomnia are not infrequent, particularly with higher doses of corticosteroids. Patients and family members and loved ones will benefit from knowing that these effects may occur with therapy. Sleep aids may be necessary for secondary insomnia. Temazepam, marketed as Restoral, or diphenhydramine are viable options. Variable increases in blood glucose and decreased glucose tolerance result from glucocorticoid use. Regular evaluation of blood glucose in diabetic patients is warranted. Glucocorticoids, especially in large or chronic doses, can increase the susceptibility to and mask the symptoms of infection, such as fever. Many consequences of long-term corticosteroid use can be detrimental. Muscle wasting, adrenocortical insufficiency, fluid and electrolyte disturbances, cataract formation, and atrophy of the protein matrix of bone resulting in osteoporosis, vertebral compression fractures, aseptic necrosis of femoral or humeral heads, and pathologic fractures are some of the most serious complications of chronic corticosteroid use. Whenever possible, chronic corticosteroid use should be curtailed. Next we will look at interactions of corticosteroids. Glucocorticoids may decrease effects of barbiturates, hydantoins, rifampin, and ephedrine. Potassium levels should be monitored when glucocorticoids are used with potassium-depleting diuretics. Next we will discuss the cannabinoids. Cannabinoids are indicated only for nausea and vomiting associated with chemotherapy. In the 1970s, it was observed that patients on chemotherapy who smoked marijuana experienced a lower incidence of nausea and vomiting. Investigators then determined that tetrahydrocannabinol, abbreviated as THC, has antiemetic properties. And now we will discuss the mechanism of action of cannabinoids. The true mechanism of action of tetrahydrocannabinol is unknown, but it is most likely related to effects on the vomiting center and the opiate receptors in the CNS and cerebral cortex, but probably does not involve the chemoreceptor trigger zone. The agent available in the United States is dronabinol, marketed as Marinol. The cannabinoids can be used to treat and prevent chemotherapy-induced nausea and vomiting. Because it is necessary to reach therapeutic blood levels of tetrahydrocannabinol before chemotherapy administration to prevent emesis, administration of the cannabinoids should occur at least 6 to 12 hours before chemotherapy. Emesis can be controlled from mildly to moderately emetogenic chemotherapy regimens, and cannabinoids may provide some relief to patients where other agents have failed. When used with mildly to moderately emetogenic regimens, tetrahydrocannabinol has been found to be superior to placebo, prochlorperazine, low-dose metoclopramide, and haloperidol. These agents are seldom front-line therapy because of their incidence and severity of adverse effects. Patients should be cautioned about the deleterious CNS effects and told not to drive or operate machinery. Dosages can be reduced if the patient is experiencing CNS toxicities. Patients should avoid alcohol and other CNS depressants. Next we will discuss the adverse events of cannabinoids. Most of the adverse effects of the cannabinoids are CNS-related and include sedation, ataxia, and dysphoria. Dysphoria may be expressed as confusion, hallucinations, anxiety, fear, memory loss, time distortion, and other undesired occurrences. Orthostatic hypotension, blurred vision, and tachycardia have been observed with the use of these drugs. With repeated doses, the patients usually become tolerant to most of the CNS adverse effects, but not to the antiemetic activity. There is a correlation between antiemetic response and a psychological high. Younger patients and patients who have had previous experiences with recreational cannabinoids appreciate greater antiemetic efficacy from this drug class. The side effects of the cannabinoids occur more frequently than with many of the other agents and are particularly distressing to older adults. One potentially beneficial adverse effect is appetite stimulation, which may prove useful in hematology and oncology patients. The cannabinoids are in pregnancy risk category D and should be avoided in pregnancy or lactation. Next we will discuss antacids. Over-the-counter, OTC, Antacid preparations may provide relief to patients experiencing mild nausea and vomiting. The general mechanism by which these agents exhibit their effects is by coating the stomach and neutralizing gastric acid. Most preparations contain one or several of the following: calcium carbonate, magnesium hydroxide, aluminum hydroxide, or aluminum carbonate. Between 15 and 30 milliliters orally of an antacid preparation may provide relief. Patients should be encouraged to seek medical attention if they experience continued nausea and vomiting, and the patient may need medical workup for more serious gastrointestinal diseases. Toxicities from over-the-counter antacids are infrequent, but they do exist. The agents containing magnesium may cause diarrhea. Conversely, the agents containing aluminum or calcium may cause constipation. These adverse effects are dose-dependent. Calcium-containing antacids can cause phosphate depletion. Caution should be used in patients with renal dysfunction because aluminum and magnesium may accumulate. Antacids, by coating the gastrointestinal tract, can decrease the absorption of many oral medications such as digoxin, some antibiotics, corticosteroids, and allopurinol, marketed as Xylopram, which may lead to decreased efficacy of therapy. For additional information on antacids, see Chapter 29. We will now switch gears to selecting the most appropriate agent. Nausea and vomiting not chemotherapy-induced. It is necessary for the practitioner to assess the etiology of the nausea and vomiting. If an organic cause can be determined, the cause should be corrected to alleviate the symptoms. For example, if the nausea and vomiting is a side effect of a medication, the medication is to be discontinued. If the cause is diabetic ketoacidosis, insulin is given. Figure 28.2 shows the treatment algorithm. Let's begin with first-line therapy. An antiemetic is selected based on patient-specific factors. Initially, a phenothiazine is used for mild to moderate nausea and vomiting. Promethazine and prochlorperazine are usually effective. Next we will talk about second-line therapy. If the above treatment is not effective, an antihistamine or anticholinergic preparation can be used. These are usually not as effective as phenothiazines but may be useful in mild nausea. And now let's look at third-line therapy. If the first two therapies are not successful, the patient should be re-evaluated for a physiological cause that has not been treated and therapy based on patient data. Table 28.2 lists the recommended order of treatment for nausea and vomiting. Let's now talk about chemotherapy-induced nausea and vomiting. Nausea and vomiting are two of the toxicities of chemotherapy that patients fear most. Although not usually a life-threatening complication, uncontrolled nausea or vomiting can greatly affect a patient's quality of life and attitude. Fortunately, new agents and combinations of agents make it possible to control emesis. The severity of chemotherapy-induced emesis depends on numerous factors. Most significant is the intrinsic ability of the chemotherapy regimen to cause nausea and vomiting. Before the U.S. Food and Drug Administration approves a drug for use, Phase 1 and 2 studies must be performed to prove efficacy and safety and identify adverse effects. The incidence and severity of nausea and vomiting are initially reported at this time, when the drug is given as a single agent. Each chemotherapy agent can be identified as having highly, moderately high, moderate, moderately low, and low emetogenic potential. Based on this information, antiemetic regimens can be tailored to the chemotherapy regimen to prevent emesis. Mechanisms to identify the emetogenicity of combination chemotherapy regimens are presented in this section. Other factors that may increase the incidence of chemotherapy-induced nausea and vomiting are previous exposure to chemotherapy, psychosocial factors such as anxiety and depression, poor performance status, and younger age, that is less than 30 years. A history of alcohol abuse and male sex may correlate with a decreased incidence or severity of nausea and vomiting. The classifications of chemotherapy-induced nausea and vomiting include acute, delayed, and anticipatory. Pause the video and carefully scrutinize Figure 28.2, which is a treatment algorithm for nausea and vomiting, before advancing to the next slide. We will now discuss acute emesis. Acute emesis is vomiting occurring within 24 hours of treatment. The onset of acute emesis is usually within 1 to 2 hours after the start of chemotherapy. It peaks within 4 to 10 hours and resolves within 24 hours, but these factors vary from agent to agent. This most common type of chemotherapy-induced nausea and vomiting is associated with a higher frequency and severity than the other two classifications. Acute emesis is strongly related to the agent or agents administered and the doses given. As shown in box 28.3 identifies the emetogenic potential of specific agents. By definition, highly emetogenic chemotherapy agents induce emesis in greater than 90% of patients receiving that drug without antiemetic premedication. Chemotherapy agents that have moderately high emetogenicity cause emesis in 60% to 90% of patients receiving chemotherapy. Chemotherapy that is moderately emetogenic has an incidence of 30% to 60%. Moderately low has a 10% to 30% incidence of emesis, and low emetogenicity is defined as an incidence of less than 10%. All patients receiving single agents that are moderately to highly emetogenic should be adequately pretreated to prevent the incidence of nausea and vomiting for at least 24 hours or the expected duration of nausea or vomiting. The current standard of care of antiemetic prophylaxis is the combination of a serotonin antagonist and a corticosteroid, such as granisetron or ondansetron with dexamethasone, at least 30 minutes before chemotherapy administration. Repeated doses may need to be given to prevent and treat emesis for 24 hours, depending on the pharmacokinetics of the agents used. Some practitioners use once-daily administration of serotonin antagonists, claiming that once the receptors are blocked, duration of receptor binding is the functional component rather than the plasma half-life. Because the purpose of these agents is to prevent nausea and vomiting, and the patient is not actively experiencing these effects, it is often acceptable to administer antiemetics orally. Combination regimens containing drugs that are moderately to highly emetogenic are given prophylactically in similar fashion. Although the aforementioned antiemetic combination is not universally effective, an estimated 70% to 90% of patients experience sufficient control. Examples of difficult clinical situations that may prohibit the use of a corticosteroid include poorly controlled diabetes and uncontrolled hypertension. Contraindications to serotonin antagonists include hypersensitivity or severe cardiac dysfunction. Alternative prophylactic antiemetics must be chosen for patients who have relative contraindications and are to receive emetogenic chemotherapy. High-dose metoclopramide with dexamethasone may be considered an option to a serotonin antagonist with dexamethasone because this was the gold standard for highly emetogenic regimens before the appearance of ondansetron. Once again, the antiemetic regimen should be tailored to the patient and the chemotherapy regimen. Single-agent or combination chemotherapy regimens that are expected to be moderately low or low in emetogenic potential can be managed less aggressively. These drugs do not warrant the use of a serotonin antagonist. For some chemotherapy regimens and agents, such as the taxanes and fluorouracil, premedication frequently is not necessary. However, patients should be encouraged to use antiemetic medications as needed to control any nausea and vomiting after chemotherapy. Premedication with dexamethasone with or without a phenothiazine or metoclopramide may be used if a patient experiences nausea and vomiting from previous chemotherapy. All of these antiemetic drugs may be scheduled for a 24 to 36-hour period to prevent any nausea and vomiting. Patient-specific factors must be considered to identify an appropriate antiemetic regimen. Regardless of the emetogenicity of a chemotherapy regimen or the use of premedications, antiemetics should be prescribed for P.R.N. or breakthrough use. Preferred P.R.N. antiemetics, such as prochlorperazine or metoclopramide, are effective, inexpensive, and easily administered. These agents provide reliable, safe control of mild nausea. These agents may be used before meals to alleviate anorexia secondary to nausea. Patients should be counseled about the common adverse effects of these agents, and each patient should be encouraged to report ineffective control of nausea and vomiting. When adhered to, the basic principles of chemotherapy antiemetic therapy, as shown in box 28.4, are tremendously effective. Pause the video and carefully scrutinize box 28.3 summarizing emetogenic potential of chemotherapy agents before advancing to the next slide. Pause the video and carefully scrutinize box 28.4 summarizing the basic principles of chemotherapy antiemetic therapy before advancing to the next slide. Pause the video and carefully scrutinize Table 28.2 summarizing the recommended order of treatment for nausea and vomiting before advancing to the next slide. We will now discuss delayed emesis. Delayed nausea and vomiting is defined as emesis that begins or persists more than 24 hours after completion of chemotherapy. Some investigators suggest that because there is a peak in incidence at 18 hours after cisplatin-based chemotherapy, a revised definition of delayed emesis should include this timetable. The newfound, reliable control of acute emesis from highly to moderately emetogenic chemotherapy regimens has unveiled delayed nausea and vomiting as a more vexing problem. Many chemotherapy agents produce mild delayed nausea and vomiting, but cyclophosphamide, cisplatin, and the anthracyclines are particularly noted for their delayed emesis. Delayed emesis usually is not as frequent or severe as acute emesis. The mechanism of delayed emesis is believed to be different from that of acute emesis. It is believed that delayed emesis is mediated by neurotransmitters, although serotonin does not play a major role. Combination antiemetic regimens have proven to be more effective than single-agent therapies. Single-agent serotonin antagonists were found to be equally as effective as metoclopramide or placebo and less effective than dexamethasone, unlike their efficacy in preventing acute emesis. Regimens identified as most effective for delayed emesis include metoclopramide 0.5 mg per kilogram orally 4 times a day for 4 days with dexamethasone 8 mg orally twice a day for 2 days, followed by dexamethasone 4 mg orally twice a day for 2 days. The use of scheduled phenothiazines, including long-acting phenothiazines, with dexamethasone is another effective option for the prevention of delayed nausea and vomiting. Addition of a benzodiazepine to the antiemetic regimen may prove useful for the control of emesis in anxious patients or patients with difficulty resting. Next we will discuss anticipatory emesis. Anticipatory nausea and vomiting occurs in up to 25% of patients receiving chemotherapy. It is usually associated with a history of uncontrolled nausea and vomiting with prior chemotherapy and is a conditioned response. Multiple factors can stimulate anticipatory nausea and vomiting, but most factors remind the patient of the previous unfavorable experience. For example, patients tell stories of becoming nauseated by the sight of their oncologist's office, or by a smell that reminds them of receiving chemotherapy. Other triggers may be tastes, sounds, or thoughts of chemotherapy. Anticipatory nausea and vomiting most frequently occurs before the administration of chemotherapy, and it can lead to poorer control of nausea and vomiting with subsequent courses. The most effective treatment for delayed nausea and vomiting is prevention. It is crucial to premedicate adequately for highly to moderately emetogenic chemotherapy and to reassess control on a frequent and regular basis. This form of emesis is frequently refractory to standard antiemetic treatment. However, the benzodiazepines and butyrofenons may provide anxiolysis as well as antimetogenicity. The addition of one of these agents is strongly encouraged for patients who have had previous unsatisfactory control of nausea and vomiting. Many practice guidelines are available for the use of antiemetics in chemotherapy-induced nausea and vomiting. These guidelines are created by experts and are based on current literature, as shown in Table 28.3 and Figure 28.3. To review treatment choices for other types of nausea and vomiting, see Table 28.2 and Figure 28.2. Next we will discuss special population considerations. Let's begin with the pediatric population. The treatment of nausea and vomiting in children differs from that in adults. It is particularly important in the pediatric population to focus on treating the cause of the problem. The etiology of emesis can vary with age, as shown in box 28.5. Because they are smaller, children are predisposed to dehydration and electrolyte abnormalities caused by emesis. Pediatric patients experience more extrapyramidal or neuromuscular reactions to phenothiazines, particularly when the drugs are administered during an acute viral illness such as chickenpox, measles, or gastroenteritis. Because of its antihistamine quality, promethazine may be a viable phenothiazine option. Also, on a milligram per kilogram basis, children experience more extrapyramidal reactions from metoclopramide, even at IV doses as low as 0.5 mg per kilogram 4 times a day. Most antiemetic agents are dosed according to milligram per kilogram of body weight or the age of the child, and many of the available agents are not recommended for use in patients younger than age 2 or 3. Some agents that are considered safe and effective in most situations are dimenhydrinate or oral or rectal trimethobenzamide, marketed as Tegan. IV not recommended. The phenothiazines are beneficial but should be used cautiously. For pediatric patients receiving chemotherapy, the prevention and treatment of emesis is similar to that in their adult counterparts, although specific pediatric dosing of the agents applies. Next we will discuss the women. Nausea and vomiting is experienced by more than 50% of pregnant women. A few women experience hyperemesis gravidarum, which can present as uncontrollable vomiting with inability to tolerate oral intake. These symptoms are most common in the first trimester of gestation but can occur at any time during pregnancy. Pregnancy-related emesis is believed to be modulated by chemoreceptor trigger zone stimulation. Teratogenicity is the paramount concern when evaluating the safety of an agent in pregnant women. The first trimester of the pregnancy is when drugs or other exogenous substances can most affect embryonal development. Many of the studies performed to study the teratogenic effects of drugs encounter several difficulties. Most fetal malformations occur rarely, and frequently only a small sample size is obtained and reported. Mothers with underlying diseases, such as seizure disorder, hypertension, diabetes, and cancer, are known to have a higher incidence of infants with malformation. In these patient populations, the role of drugs versus the role of the disease in fetal abnormalities is unclear. Recall bias may play a factor in teratogenicity studies as well. Ultimately, current evidence-based information on the safety and risk of drugs during pregnancy should be used to make clinical decisions. Agents that are used for mild to moderate nausea and vomiting in pregnancy include the phenothiazines, antihistamine anticholinergic agents, and metoclopramide. Antihistamine drugs are generally believed to be safe for the pregnant woman and her fetus, although there are incidental findings of malformations in fetuses exposed to antihistamines. Anticholinergic drugs have been proven to cause neonatal meconium ileus. Conversely, some anticholinergic agents such as scopolamine have not been associated with consistent teratogenesis. Phenothiazines readily cross the placenta, but the bulk of evidence indicates their use is safe in this population. Antacids, such as calcium carbonate, may provide safe and reliable relief from mild nausea. Antihistamines, phenothiazines, metoclopramide, haloperidol, droperidol, and ondansetron have all been used in hyperemesis gravidarum without adverse fetal sequelae. Drug classes that should be avoided in pregnant women are the benzodiazepines and cannabinoids. Increased rates of malformations and fetal complications have been associated with the use of these classes of agents. However, the use of other prescribed and illicit drugs by many of these mothers could cloud the picture. Corticosteroids are rarely used for the control of nausea and vomiting in pregnant women. The risks versus benefits of each drug and situation must be weighed carefully. Further studies to assess safety in this patient population are greatly needed. Pause the video and carefully scrutinize Table 28.3 summarizing the recommended order of treatment for chemotherapy-induced nausea and vomiting before advancing to the next slide. Pause the video and carefully scrutinize Figure 28.3, which is a treatment algorithm for chemotherapy-induced nausea and vomiting before advancing to the next slide. Pause the video and carefully scrutinize Box 28.5 summarizing differential diagnosis of vomiting by age before advancing to the next slide. Next we will discuss monitoring patient response. The best measure of nausea control is how the patient feels. To make evaluation of nausea more objective, nausea can be rated as none, mild, moderate, or severe. Another method is to ask the patient to rate the nausea on a scale from 0 to 10, with 0 equal to no nausea and 10 equal to severe nausea. These methods may help to compare nausea from day to day or week to week in the same patient. Vomiting is easily quantified by episodes per day and volume. If the volume of vomit exceeds 200 to 500 milliliters per day, the patient should be evaluated for electrolyte abnormalities. We will now briefly talk about patient education. It is pivotal to identify the cause of the nausea and vomiting and to educate the patient about actions that need to be taken. Many cases of mild nausea and vomiting can be alleviated without additional medications. Next we will look at drug information. Some drugs may be taken with food to avoid gastrointestinal discomfort, and dietary adjustments may prove to be helpful for some cases of nausea. This knowledge gives patients more control over their own well-being. Anxiety and mental illness are components of some occurrences of nausea and vomiting. Therefore, counseling and education are the key components in the treatment of nausea and vomiting of this type. Patients can also be educated about the non-prescription drugs available. Realistic goals of nausea control should be set and discussed with the patient. For example, many women have morning sickness with pregnancy. However, Medications should be used as infrequently as possible at the lowest dose possible. With antiemetics, as with any other drug therapy, usual or serious toxicities should be reviewed with the patient. Extrapyramidal symptoms are frightening and uncomfortable. Consequently, patients need to be aware of this potential effect and how to reverse it if necessary. Diphenhydramine. Sedation and anticholinergic effects are common with many antiemetics. For most antiemetics, encourage caution when using machinery or driving. Proper administration of the medication should be reviewed. Will the patient take this on a schedule or only as needed? All of this information ensures that the patient has optimal benefit from the prescribed medication. We will now move on to nutritional and lifestyle changes. Maintenance of proper hydration during all forms of vomiting is important and should be emphasized to patients predisposed to nausea and vomiting, e.g., children, patients following surgery and chemotherapy, patients with gastrointestinal disorders and infections. Rehydration with clear liquids is preferred over colas, milk, or caffeinated beverages. Patients should be educated on when to seek medical attention because of excessive vomiting or dehydration. Lastly, we will shift gears to complementary and alternative therapies. Patients suffering from nausea and vomiting of pregnancy, abbreviated as NVP, frequently do not receive therapy, in part because of fears of adverse effects of medications on the fetus. Several vitamin-based and herbal therapies have been shown to be effective and safe. 2 randomized trials of vitamin B6 have shown a benefit in reducing nausea and vomiting of pregnancy. The recommended daily allowance is 1.3 to 2 mg per day. Women taking prenatal multivitamins are less likely to have severe nausea and vomiting of pregnancy. Ginger has been shown to reduce nausea and vomiting of pregnancy. Ginger appears to work by inhibiting serotonin receptors in the gastrointestinal tract and CNS. The dose of ginger for the powdered root form in motion sickness is 1 gram up to 4 hours before an inciting event. In nausea and vomiting of pregnancy, 250 mg 4 times a day. For chemotherapy-induced nausea and vomiting, 2 to 4 grams daily. And for postoperative nausea and vomiting, 1 gram 1 hour before anesthesia induction. Vitamin B1, also known as thiamine, deficiency can lead to Wernicke encephalopathy in women with severe nausea and vomiting of pregnancy. Replacement is needed for all women with vomiting of more than 3 weeks duration. Prophylaxis with multivitamins and therapy with B6, with or without doxylamine, are safe and effective therapies for nausea and vomiting of pregnancy. Thank you.